Now, Dr. Fauci, you have said that you think it's likely that in the winter, this virus could come back as the Spanish flu of 1918 came back fairly lethally. Why do you think it will come back?
Well, David, I'm almost certain it will come back because the virus is so transmissible and it's globally spread. Remember, all kinds of viruses like this, when people are indoors and congregated in the cold, dry weather, they tend to do better than when you're in a warmer climate. I don't know whether that's going to make a major difference here, but what we do know is that right now, as we start to stabilize Southern Africa, places like KwaZulu-Natal in South Africa and Cape Town and other places are starting to see the emergence of cases. So it's not going to disappear from the planet, which means as we get into next season, in my mind, it's inevitable that we will have a return of the virus, or maybe it never even went away. When it does, how we handle it will determine our fate. If by that time we have put into place all of the countermeasures that you need to address this, we should do reasonably well. If we don't do that successfully, we could be in for a bad fall and a bad winter.
So how do you look at testing? Other countries, they have taken on testing. The nation itself, the country has taken on the testing. Here, we're letting the states take it on. Why is that the best way to do it? And if somebody wants to get a test today, can they realistically get one?
Well, David, there's no secret because I've been public about that early on with our testing capability. It was not really properly designed for what we had to deal with in such an acute way. And it actually did fail us early on. I've said that before, so I'm not creating any new dialogue here. However, we have responded now in a very aggressive way and appropriately for the way our country is built. Namely, we have engaged the private sector, the big companies who know what they're doing, who do this for a living. And right now, over the past several weeks and into the future, the testing situation has improved very rapidly. Whether or not we're exactly where we want to be, that remains to be seen. I think we are either there, David, or getting very close to being there. Yesterday, the plan that was rolled out was a blueprint for testing as we open America again. And the thing in that's now different, and everyone should understand that, it is really a true partnership between the states and the federal government, where the implementation on the ground should be at the state level because they know what they're doing. But the federal government has a role in providing strategic direction and technical assistance. And that's something that wasn't fully in place early on, that right now there's a commitment of that partnership between the federal government being kind of the supplier of last resort, but also the group that allows the interaction with the states so that we can give them strategic direction and then let them do at the local level what they do very well. So I believe we are much, much better off now than we were several weeks ago.
Do the tests work? Are there a lot of false positives or false negatives on these?
The validated tests that are out there are sensitive and specific. No test is 100% perfect. I think people sometimes get confused about what test you're talking about. There are two major categories of tests. One is a test for the virus itself. Those tests, there are multiple different platforms that get you there, some more rapid than others, some using different approaches. But the bottom line, it tells you whether you are infected or not at this particular time. There's another test that is now being worked on. Many of them are out there that have not been validated, but a few have been validated by the FDA, and that's an antibody test. It doesn't test for whether you are infected now. It tests of whether you have been infected and likely recovered and now have antibodies, which are proteins that the body produces in response to an infection. And most of the time, It protects you against being infected by the same virus again. The degree to which that protection exists still needs to be worked out for this particular virus, because this is the first time that we've had any experience with this type of virus. So one group of tests for the virus is quite solid. The other is working its way now into being more solid.
Now, vaccines. What is the status of vaccines? There's a report in the New York Times today that your lab and Oxford University are working on something that seems to have worked in monkeys. What's the likelihood that that vaccine could actually turn out to be good for humans?
Well, certainly it's possible, and I'm cautiously optimistic that not only that candidate, but a number of other candidates that we at the NIH are partnering with our pharmaceutical colleagues, and some companies and countries are developing vaccines totally independent of us. There are going to be a lot of candidates out there. As you know, a few of them are already well into phase 1 studies in humans to determine if it's safe. And hopefully we can move along rather rapidly to get an answer, are they safe and effective, in a timely manner, which I've said right from the beginning would likely be a year to a year and a half. I said that a few months ago. Hopefully by the time we get to this coming winter, that we will know whether or not we have a safe and effective vaccine. And then the challenge will be to scale it up enough to be able to distribute it meaningfully, both in this country and throughout the world. And that's the reason why, as important as getting a vaccine that you show works and is safe, is the ability to scale up enough doses so that it isn't confined only to rich countries, that the rest of the world can have access to it.
So we never really came up with a vaccine to prevent one from contracting HIV. I think that's right. We don't have a vaccine to prevent you from getting HIV. So why are you optimistic we can get a vaccine for this? Because a lot of work's been put on HIV as well.
Well, there's a big difference with HIV, David, and I'm glad you brought that up. Because with HIV, whenever you make a vaccine, what you rely on is the ability of the body to make an adequate response to natural infection. So we know that measles is a serious disease, but the body clears measles in the overwhelming majority of individuals and leaves those people with an immune response that protects them against reinfection. So measles has already proved the concept that the body can make a good response. That's not the case with HIV for reasons that are very perplexing. The body does not make a very good response against HIV that can protect them, which is the reason why, of all the millions and millions of cases of HIV, there have been really no instances of spontaneous removal of the virus from the body purely on the basis of your natural immune response. However, with other viruses, including respiratory viruses, we know the body does make a good immune response. So many, many, many people recover from coronavirus infection, this novel coronavirus, which is giving us so much trouble. So the very fact that people can mount a natural immune response that gets rid of the virus in them makes me cautiously optimistic that we can develop a vaccine that can mimic natural infection enough to induce that same sort of response that would ultimately protect people. So there's no guarantee, David, there's never a guarantee of success, but the fact that the body can do it gives me cautious optimism.
But could COVID-19 mutate into a COVID-20 such that the vaccine wouldn't be adequate for a mutation of the existing virus?
That is always possible, David. It likely would mutate less to make it evasive of the vaccine than it might to make it a little more or less virulent or a little bit more or less resistant to a drug. For it to mutate so that the vaccine doesn't work is possible and could occur. And that's the reason why you need to do carefully designed and well-controlled studies to look at the efficacy and match it against the immune response to the particular virus that happens to be currently circulating.
And why do you think this virus has been so damaging to people who are elderly, people over, let's say, 60 or 65 or something like that, or people who are African American or other people of color? Why do you think that's the case?
Well, one of the issues that's very clear is that even if you look at influenza, which we have a lot of experience, influenza and other types of viruses always hurt the elderly and people with underlying conditions more than healthy young people. The interesting thing about this infection is that, for the most part, with some exceptions, it is very heavily concentrated towards people who get into trouble or those who have the underlying conditions. That is mostly hypertension, diabetes, obesity, some chronic lung disease. We don't fully appreciate and understand what I call the pathogenic mechanisms of this virus. But as we learn more about it, we see that it has a complicated way of hurting the body. But if you have an underlying condition, as with many viruses, it makes you much higher at risk, not of getting infected, but of actually getting a deleterious consequence. With regard to African Americans, unfortunately, the disparity in health that has nothing to do with coronavirus that we've known forever is that the African American community suffers disproportionately with those diseases like hypertension, like diabetes, that actually give you a greater possibility of having a poor adverse outcome. So it's a double whammy. They disproportionately have these diseases that are bad enough to begin with, and that puts them at additional risk of getting a very poor outcome when they do get infected.